So yeah, it's very important to organize things. I have to organize my material that I understand it in my own way. That's why you got the booklets.
Yeah.
So I understand it, you know.
Yeah.
I mean, it's a process, but you know, it started with flashcards, and that becomes the text of the booklets. Is like take all the weird wording out, and keep the minimum, and try to make it so it's still understandable, and then add a lot of pictures to it to explain it.
I like it. Yeah, it's a lot better than a textbook. Very much, so much more like engaging too.
Well, and it's not like it's not a lot of material. It's plenty of stuff, you know.
Yeah. Oh yeah.
It's definitely plenty of material there, especially in a 9-week course. You guys are going crazy.
Oh yeah. It is really fast.
It's very fast. Normally it's a 16-week course, but you know. Hi, Hannah.
How is that?
Oh, go ahead.
I was gonna say, how has that been for you from going to like teaching it in 6 weeks to trying to fit it into 9?
Well, I just have to make sure I grade once in a while, and I don't let too much time go by between the grading. I have a little more leeway in the 16-week. It's going to be interesting with the test 2. Test 2 is very heavy for me to grade.
Oh yeah, it's a matching, right? And fill in the
blank. No, it's a fill in the blank.
Okay.
Yeah, we can actually go. Make sure you ask that question. We can go do an example of the test, so that that way, you know, I want to make sure. The technicalities don't need to make you guys worried. That's, you know, if we worry about anything, oh shoot, I didn't study at all. That's, we can have that be the worry, but I don't want the technical aspects to be a problem. Hi, Hannah. How are you? Oh well, can't hear you.
Oh, sorry.
Oh, there you are. How are you?
I'm good. How are you?
I'm good. I'm good. And look at that. We get Jonka coming in. Hi. Hi, Jonka. Oh, she's gone.
I think she might have got kicked out.
Yeah, she probably, huh? Well, what I wanted to do today is this is our first meeting since test number 1. Is that correct?
Yeah, because we didn't have one last week, right?
Yeah, last week was break time.
Yeah, okay.
Although, of course, I gave you plenty of work to do.
Yeah.
Well, otherwise it kind of ain't going to happen when we get through the course. How was test 1? Are there any things that is questionable that you need to have me talk about?
I only missed the first one, I think, and me and my brother were going back and forth. I was like, no, and then I ended up being wrong. But it was
wasn't too bad, huh?
Yeah, no, it was about protein being hydrophobic.
Oh, he's hydrophilic.
Yeah.
Everything except the oil is hydrophilic.
Yeah, so that's where I got mixed up. But other than that, it was pretty straightforward, and I got pretty much everything else.
Okay, no, it seems like most of you guys did good in terms of the test, so that's good. Then today, what we're gonna have to do is we're gonna go through the skeleton. So we actually, this week is kind of this. Well, last week was kind of skeleton, and then this week is muscly stuff. And so, from our perspective, we'll talk about skeletal this week, and then we'll touch on muscles next week. All right.
Yes.
So let's see. What I want to do is, do you have your term list, right? I want you guys to take out your term list.
We're in unit 2 now, right?
We're in book 2. Yeah, unit 2.
Okay.
So when I look at, well, you have the term list, but let me go right now to how I'm structuring that second test. Can you guys see my canvas?
Yes, I can.
Yes.
Good. So we have test 1 is finished. So now we're going to go through module 5 through whatever it is down here, lower extremity muscles. And then we have a test 2 coming up. And what I want to make sure is you take a look at the FYI thing there, the test review videos and test pictures. Because what I've done, when I still had some hair, what I've done is I made 4 videos that basically touch on all the landmarks and muscles that we need to study for test 2. And so you can, some students, what they do is they just watch these videos over and over, because I'm using the modules that are in the test in these videos. These are a few years old, so some terms might be slightly off, but for the most part, it's all in there. And then here you have an ability to print out the term list again. And then this here, pictures used on test 2 is, oh wait, I gotta show you this way, is this here. Bird, come on, bird. Oops. So what you have there is a document that basically is a collection, like 14 pages of pictures of models, which are the pictures I'm using for the test. And so this is actually a good document for you guys to, it's a PDF. I just have it in Word on here. But this is actually a good document for you guys to either print out or put it on, you know, on electronic device. And then that's where it is right here. And then you can use it as a practice sort of thing. If you can label the stuff on those pictures, you're good. Because let me show you how we're gonna do. What does your brother play, Natalie?
Football.
Football.
I know.
Careful with that head.
I know, not good for the brain.
I know, huh? Oh well.
Yeah.
So, oh, I went to the wrong place here. Let me go to modules. Yeah, since the Raiders moved, I don't have football players no more.
How did you like working with them? Were they like, was it a lot harder to work with them, would you say, or no?
Honestly, some were really nice and some were jerks.
Yeah, I feel like
too much money for too much money too soon.
Yeah.
And so it kind of rubs off some, and some were really, really nice. I had some really nice players too. Yeah, but it's not my favorite group because being on time is a bit of a challenge and so forth.
Oh yeah, tell me about it. I live with one of them.
Oh, there you go, huh? So what I want to show you is this is actually the test that you're gonna have to do, and the way that it works. Oh God, of course it's very slow because I have so much stuff open, working on all the stuff, and so all that I'm asking you are terms from the term list number 1, which is wherever I have that. You have that.
Yeah.
And so it has. So if it's not on the term list, don't even worry about looking for it.
Okay.
And so that way we narrow down, it's still enough of information that you need to know. But that way you're not looking around and go like, oh my God, it's like everything. It's just the terms from the term list. And so what I do is I ask you guys either for a bone or a landmark or a muscle, 3 things. Okay. If it's a bone, I want you to tell me the whole bone. This would be the frontal bone right here. If it's a landmark, it's part of that bone. So like here, number 1, which you're gonna get one right for sure, because it's the actual test. So number 1 shows you a landmark, and that's part of the frontal bone. So this here will be the glabella, which is on your term list. And so what I did is I did a picture, and then I took a video of it. All right, the first question is a landmark that is between the superciliary arches. And so you can get a view of that through a video as well, and not just a picture. That way, hopefully it's clear. And then down in here, I need you to write it in what it is, and you just copy the test you copy the term from the test, from the term list. And you write it in here, and then you go to the next one. Okay. All right.
If we don't spell it correctly, is it automatically going to mark it wrong?
Yeah, it depends on the Yeah, if it's misspelled, it will call it wrong. And that's where I go in the background and I correct everything. And of course, the misspell is fine. Unless it spells a different word, it's going to be okay. You know? So that's where you want to, and it's a good question because that's where you go like, I finished, I thought I did okay, and I only got this many right. What's wrong with me? Yeah. And the problem is the program, I can put all the answers behind I wanted to recognize, although sometimes it even says it's wrong when it's in there. And so, you know, I have to just go through it manually. And I just put all the different possibilities that I can think of, and I also learn of what students put, and then hopefully more and more it gets corrected. But the misspellings are a little hard to pick up. Yeah. And so don't worry about the misspelling. Okay. You know, just worry about if it spells wrong another thing. I think what people get mostly wrong in this test is the differentiation between a bone and a landmark. Mm-hmm. Do I want the whole bone or do I just want part of the bone? Yeah. And the other one that I often get is that they do more terms that are on the term list. Okay. And so those are, and so I'm hoping that people listen to the recording so they get that.
And is it going based off of the term list 2, or is it like a combination of term list 1 and term list 2?
It's only term list 1.
Oh, it's only term list 1.
It's only term list 1 because term list 2 is going to be in the last exam. Okay, got it. In the final exam. Does that make sense? Yeah. All right. Now what I need to find, I did accounting this afternoon, so I'm all discombobulated here. Hold on. See on my t-shirt. So what I want to go through is basically I want to take out term list 1, and we're just going to go through those terms on that term list 1. I want to make sure you're all getting those. All right. And I'm going to pull out the booklet that I need for that. I hope my computer is going to handle all of that. I have so much stuff open. So let me pull this up real quick. So the first chapter we're going to do is the skull chapter. Very interesting stuff, right? Right. PowerPoint here. All right, let's see. Maybe we just put it from
booklet 2, correct?
Yes, it's booklet 2. Oh, and let me make sure I put you guys' name down. I got Natalie here. I got Hannah here. And I got Janka here. I wonder if it's difficult for people to come because it's in the middle of the afternoon. I think so, right?
Yeah, I just rushed here right now from practice, actually. I probably look like really red.
Oh, you're also, you're what do you practice?
I play volleyball.
Oh, cool.
Yeah, I love it. Jenka said she's at work and she's tuning in.
Oh, cool. Okay, I got it. Perfect. So you guys can see my PowerPoint?
Yes, we can.
Okay. So basically, we're just going to go right through the skull. So we have the first bone that we talk about is the frontal bone. And these should correspond with your booklets. I just do it from the internet. So I don't have that much data. So you see on the term list, I have frontal, there it says bones, and then it says frontal bone. And underneath frontal bone, I got a couple of terms. You see that are sort of in there, superciliary arches and glabella. So the terms indented are the landmarks, and the terms to the side are more the bone. So the frontal bone is the one in the front of the head, this one right here. Mm-hmm. And on there, there's multiple landmarks, but I'm focusing on 2 of them. I'm focusing on the glabella and on the superciliary arches. The superciliary arches are the eyebrows, and the glabella is in between the eyebrows. Okay. So far, so good? That's pretty straightforward, right?
The glabella was the one that you showed us right now, right? A second ago? That was on the test?
That's always on the test because glabella rhymes with my daughter's name, Isabella. And and unfortunately, she has not been living with me since she's 5 years old. And so I always have to remember her. I just talked to her today. We're having a great time. She's 18 at this point.
Oh, wow.
Yeah.
I'm 18 too, so.
Yeah, so see, there you go. Same age as some of you guys, probably. Yeah. I did a lot of these concepts. I taught her when she was like 12 or 13 to see if they're too complicated or not.
On her brains.
Yeah, so that was good, right?
Okay.
Well, you know, Einstein, you guys know who Einstein is, right?
Yes.
Einstein said, make it simple, but not simpler than that. So, you know, that is what we talked about is the textbooks. What frustrates me is when the textbooks try to make it more complicated than it has to be.
Yeah.
And I figured if I pull from Einstein, I'm in pretty good company.
Yeah.
And so, and you know, Einstein was somewhat Swiss, so I, you know, he went to school in Switzerland for sure. Anyway, the second, well, it's interesting because in Switzerland there we have a lot of apprenticeships. There's a lot of hands-on learning, much more than in America, and also from a background of teaching. The main pedagogical father of our school system, which was like 1800s, had a philosophy to bring the mind together with the heart and the hand. And so integrated teaching seems to be much more common there than here. I find it often very theoretical.
Yeah.
You know, and so I think it's important to keep that in mind. That, you know, not that we can change it, but if it's hard and frustrating, we understand it just is that way. It doesn't have to be, but it is that way.
Yeah.
And then we can adapt a little. So when I look at the other, so on the parietal bone, that's the parietal bone here. These big bones on the side of the skull. So the main bones on the head on top are the parietal bones. And in between the parietal bones, we have a suture. And the suture are joints between the skull bones. That's what we call sutures. And the one I want you to know, there's the sagittal suture. The sagittal suture. In chapter 1, you'll learn about the sagittal plane a little bit. And so that's just the suture that goes right down the middle, separating it to right from right to left. So that's the term for the parietal bone. And then we go right to the occipital bone. We just keep moving. Again, you guys just interrupt me if you have a question. You don't have to hold up the hand or anything. This is that way I can keep talking. And if nothing comes, then we get through the material in a good amount of time. But yes.
So if you ever had like brain surgery or something like that, is that where they would go through?
What?
The sagittal suture?
No, they will cut open a bone part.
Oh, okay.
Because these sutures are like really dense. There's like one layer of cell or so in between those bony plates. And for a lot of the texts don't even say that these joints can move, although they have been proven wrong clinically because you have techniques like craniosacral therapy. Or I actually do a technique if somebody has a whiplash or a concussion. Yeah, listen up for your brother. I do a technique where I take a balloon and put a balloon on a blood pressure cuff, like a little finger glove, you know, one glove that just goes on one finger.
Yeah.
And I put it on a blood pressure cup to put air into it. And then I guide it into the nostrils here and pump it up. And it basically moves those bones around a little bit. And so it's so you do know these joints, they do move. Yeah, my teacher who taught me that technique had a patient who hit her head on the half pipe and couldn't stand on one leg, and he treated her for 6 weeks, and then she won the gold in Vancouver on the Olympics.
Oh wow. Well,
So yeah,
I'll have to demonstrate it so I know how to help him.
it's actually interesting. I mean, it's not that difficult of a technique. It's just not taught, and it's, you know, and it's a balloon. It's a little uncomfortable, but it's really not a scalpel or anything.
Yeah, and it's a lot better than having a concussion.
Oh yeah, you know, medically it's very hard. I mean, there's some research from the University of Pennsylvania, I think, in terms of their sports teams that talk about nutrition with concussion. So if there's ever anything, you just reach out to me, even after class. Don't feel bad about that. So at least we can talk about those things.
Yeah.
But generally, the medical community, again, in part, I think because they are hesitant in understanding that sutures actually move and they think they're fixed. But if there is, why would they be fixed if there's a space in between them?
Mm-hmm.
You know, that's just not logical. Anywho, I don't have to go against medicine too heavy. You guys are gonna make sure I'm not too gruff. And don't get me wrong, medicine is fantastic. It's just I feel like it's very important for us to, you know, learn about it and learn some of the nuances that we can make good decisions later on. The occipital bone is the back portion of the skull, and we have a few terms there. We have a big old hole, a foramen magnum. A foramen means a hole. That always means a hole. And the foramen magnum is where the spinal cord goes up and down. So that's the connection between the brain and the rest of the body. So that's a pretty important hole right there. And then we got these occipital condyles. And the occipital condyles are on the outside. They're on the bottom here. And they make a connection with the first cervical vertebra, which is C1, the atlas. And so that's what those are. And then we also have the external occipital protuberance. Protuberance, I'm always saying it wrong. I actually wrote it wrong for a long time. Not protuberance, is protuberance. And that's the, if you reach back behind your skull, on the bottom there at the base, there's a big bump. And that's the big bump. That bump is the external occipital protuberance. And mostly when we have bumps like that, it ends up being muscle attachments. So actually the trapezius muscle goes into here. And we'll talk about the trapezius muscle later on. Good. And then that brings me to the temporal bone. And the temporal bone is behind the ear. So we have a few, that bone looks pretty interesting. So we have a few structures there that we want to talk about. We have the mastoid process right there. And the mastoid process is, if you look at, this is where the ear is. So if you look right, your ear lobule a little bit in front, no, a little behind it. That's behind, that's the front, that's the behind. That is a little bumpy bone that you can touch. And if you press on it, it might hurt us slightly. And that's because that bone in there is porous. It's spongy bone. It's not compact bone. And that's the mastoid process. If you ever heard of the mastoiditis, is when that becomes inflamed. Whenever you see the word itis, I-T-I-S, on something, you're thinking inflammation. That's good to know that. Like arthritis is inflammation of the joint, et cetera, et cetera. And then the next thing we have the mastoid process, then we have the mandibular fossa. And the mandibular fossa is right here in front of what's the external acoustic meatus. Meatus means canal, means sort of hole, because sometimes these are labeled as external acoustic canal, or instead of acoustic, sometimes they use the term auditory as well. So all these are the same thing. They are the ear hole on the outside where you can stick your finger in on the ear. So that's the external acoustic meatus. That's on your list. And then right in front of that, we have this indentation. And an indentation is a fossa. That's often used as a term for that. And if you look at the picture right here, that's a place where the mandible goes in. So a fossa is often a shallow indentation that has a joint that connects to it, or a muscle attachment. And so the mandibular fossa is connecting with, let's see, do I have that on the list too? On the maxilla, on the mandible. Yeah, see on the mandible, if you go down a little bit, I have mandibular condyle. And that's the part of the mandible that fits into the mandibular fossa right here. So that's the jaw joint. Have you ever heard of TMJ?
No, I haven't.
You guys are too young. Nobody has a TMJ problems. You know, chewing problems and it clicks, or people that grind their teeth at night.
Oh, my friend does that, which is really, really bad.
Yeah, see that? I used to do that too. And that joint can get impacted by that. So if somebody can't open the mouth wide enough, or it hurts when they close it, we look at that joint because it often has a problem in it. It's quite complicated because you have two of them. You have one on the right and one on the left, and they have to work very nice in synchrony. If one of them is off a little bit, the whole thing gets crooked. And you might not see it because it's just a little bit crooked, but obviously it's going to hurt when we eat it. Yeah, so that's important there. So then we can go back to the temporal bone. I have the styloid process. And the styloid process, stylus, you know, a stylus is a pen, like a stylus for the phone or for the iPad or something like that. So that's the terminology. And the styloid process is a little bony thing that sticks out underneath the ear canal there, and it has muscles attached to it, small little muscles that help with swallowing. So that's that. And then at the last term on that bone is if we open the skull and we look down on the skull, here's the foramen magnum. And then, why is this going like that? And then there is next to the foramen magnum, there is a little raised area that's kind of like a hill that you got to go over. So it's a little raised. And in there we have the inner ear. So when we talk about hearing, see here, there's the hearing apparatus and also the balancing apparatus. They're carved out in bone, which is kind of cool. I mean, all of this stuff is really freaking cool when you actually think about it. Magical in many ways. And so that raised area there, that little bump, that's the petrous portion. And so you can see it here, or of course in a cross section, you can see it here. The pictures where I'm going to show it on the test is going to be here, if I use it on the test. And then one of my favorite bones, the sphenoid bone. And sphenoid means wing. And the sphenoid bone is really cool. That's the key bone. So when I talk to you about that maneuver with the balloon up the nose, what you actually do is you put it right underneath the eye socket and you pop it up a little, and it clicks that bone back slightly. And all the other bones from the skull are attached to that bone. And so you can free up joints, you can free up fixations in the sutures that way. And the sutures need to move a little bit because the brain expands slightly and contracts slightly. It has a breathing to it because it's a hydraulic system. When the brain is when we talk about the brain is enclosed with water and liquid. And it's called cerebrospinal fluid. It's very liquidy. So what it does, it takes away the gravity. So the brain doesn't collapse under gravity. So that's kind of interesting. We'll talk about that when we come to the brain. Anyway, the sphenoid bone is that bat-shaped bone that goes across the skull and is part of the eye socket. And you can't really see it from the outside that well. But what we have is when we open the skull, let's see if I see it better here. When you open the skull, this yellow bone is the sphenoid bone. And you see there's this indentation right in there in the middle. And that's the Seletourcico. That's known as the Seletourcico. We have it labeled right here. Seletourcico is right this section here. It's not as easy visible as it is on this previous picture because you're looking straight from above down. And the Seletourcico is important. It's a place where we have a gland. So we have the pituitary gland sitting that bone thing. And the thing is, glandular tissue, we learned, is epithelial tissue. And epithelial tissue grows rapidly and multiplies. And brain tissue, nervous tissue, does not do that. And nervous tissue is very, very soft. And so what can happen is that the pituitary gland grows out of bounds and pushes onto the brain structures, and we don't want that. And so therefore what the body did is it enclosed it as much as it can in bone, so it cannot push against the bones very hard, so it cannot grow into the bone. And so that's what that is. So that's the Seletourcico. Turkish saddle is what that means. Because when you look at a Turkish saddle, it looks kind of like similar to this for some reason. Although I think these were people that had a lot of wine before they made this terminology up. Well, it's kind of helpful if it's visual language that they use. It's just we have to know what it means before it makes sense, right? So the next bone is the ethmoid bone, and the ethmoid bone is another one of those small little bones, and that's basically behind your nose. That's the stuff behind your nose. And so if you stick your finger into your nose, you're going to touch some ethmoid bone. So you have like the perpendicular plate is between the two nares, the two holes in the nose. Let me see. Oh, we don't have that as a term. But what we do have as a term is the crista galli and the cribriform plate. And those are important. They're like really on top here. So the cribriform plate, you see here, these holes there, these little white spots, those are holes in the bone. And those are where the smelling nerves go through. And so the olfactory nerves, those are the smelling nerves. They have receptors that are on the roof of the nose. So when you breathe in, you smell stuff, especially when you breathe in deep through the nose. And then the nerves translate that smelling sensation through those holes and deliver the nerve impulse to the brain. So that's pretty cool. Let me see if we have a better shot of that. See here, this is a better shot of that. See here, you got little dots. That's the cribriform plate. And then the middle portion of it is a little bone that sticks upward. And there is a structure attached to that separates the right from the left part of the brain. But that portion there is known as the crista galli. And that's like the comb of a male chicken. So that's what that terminology comes from, crista galli. If I have a test question on that, I kind of take those two terms interchangeably because it's a little hard to differentiate them on a picture.
Okay.
All right, then we get to the maxilla, and the maxilla is the upper jawbone. That's where the upper row of the teeth are attached to. And the term that I need you to know there, besides the bone, is the palatine process, and that's the roof of the mouth. So if you stick your tongue up in the roof of the mouth, you touch in your palatine process. And see here, there is a little cut, and behind there is another bone, and that is actually its own bone. That's known as the palatine bone, right in there. Well, it looks like that when you take it out, but when you put it back into the mouth, it's this piece like there. You can see that at the end of the roof of the mouth. So that's the palatine bone. And then I do ask for the nasal bone. And that's just because it's easy. The nasal bone is the bridge of your nose. So that should be hopefully not too hard to remember that. And then the next bone I like is the zygomatic bone. And the zygomatic bone is your cheekbone. So that's where the cheeks are. And that's a cool, I like that because the name is really cool. And there's also muscles attached to that we're going to talk about. Oh, actually, you guys did the facial muscles, right? So we're going to talk about those next. And then what's next here is the maxilla. The mandible is the last one that I worry about in terms of the test situation. And the mandible is the lower jawbone. And what you need to know about the mandible is that mandibular condyle, that's in the back, not to be confused with the second portion, which is the coronoid process, which is kind of annoying, such a complicated word. So coronoid goes together with annoying, kind of. So maybe that will help you remember it. But the condyle is what makes the joint with the temporal bone, and the coronoid process is actually where we have a muscle attached to, one of the chewing muscles that we're going to talk about. And then I need you to understand the side of this bone, the bar-like kind of part is the ramus, and the piece that goes around the front is the body of the mandible. Good. Any questions to that?
No, not any as of now.
No, yeah, and if you have questions, just shoot me a text and we'll, figure out how to make you understand it, or, or have a little Zoom class amongst ourselves. and figure it out that way. So do not hesitate, even if you listen to this recording, do not hesitate to just reach out to me. And the best way to do it, as you've noticed so far, is via text. Then the emails I might be missing for a couple of days. So I got like 3 or 4 friggin' email addresses I got to look at. It's a little bit annoying. But that's, besides. Hey, how did you like the mugging with muscle chapter? With the facial expressions?
Oh, I liked it.
You,
it was like it was cool to see like why my faces make the faces they make sometimes.
Oh, that's good, because that was my original. This is my original chapter that I didn't get from anybody else's book, because I'm like, how am I going to teach these boring muscle names?
Yeah.
And I saw some of you guys. I think Janka. Do you say Janka or Janka? I see that word come.
Yeah.
I did not unpublish one of the exercises in the face, which is making facial expressions, which is kind of involved. So what I did, and some people like Janka, she did it already, but I put it as extra credit because I meant to take it out, meant to be an exercise for in class. When I need to make sure people are busy so they don't look on their phone for like vacations in the Bahamas or something. Or summer things. That's when I came up with those. All right, so when we look at the muscles of the face, let's just see what we can catch here. Nah, that's not that great. We have a few of them that I touch on. We have the first one I want you to understand is the frontalis muscle. And guess what? The frontalis muscle is on top of the frontal bone. It's in the front of your head. So if you walk into the wall, you probably walk head first. That's the front of your body. It's the frontalis or the frontal. And then when we get to the brain, we have a frontal lobe in the brain. So it's kind of helpful a little bit that way. So that muscle, and again, in my tests, all you need to know, oh yeah, that's good to mention that. All you need to know is label the muscles or name the muscles when I label it. You do not need to tell me what's the origin. O stands for origin, right? I for insertion, and A for action. You do not need to give me those details. You just need to label the muscle. Okay?
Okay.
Then we have corrugator supercilii muscle. That's the one that makes the anger motion, that makes these furrows here. So that muscle that's on top of the glabella. And then we got a couple of round muscles. We got one around the eye, and that's the orbicularis oculi. Eye is oculus. And then further down, you see one that's the orbicularis oris, and that is a muscle that goes around the mouth, if I find that on here. We'll get to it. Maybe I could just show it here. So there's a round muscle around the mouth, and that's going to be the orbicularis oris. So orbicularis means round muscle, oculi refers to the eye, and oris refers to the mouth. And then I got this long name. This is the longest muscle name we have. So once you went through that, you're cool. But I'm not going to ask you on the test for it. It's too complicated to spell. But I do bring in the nasalis muscle, because guess what? That muscle is on top of the nose. So if you have a muscle that I indicate on the nose, you can call it nose muscle, the nasalis. And then I'm going to go to the couple muscles that are on top of the lip, and then a couple muscles that are below the lip, and a couple muscles on the side of the lips. So the round muscle that you can sort of make out here and a little bit on the bottom is the orbicularis oris. And then a muscle that goes from the corner of the mouth. Well, I'm not going to indicate that because that's confusing. We go from the corner of the mouth to the cheekbone. And that muscle is the zygomaticus muscle. Zygomaticus muscle. So you got it right here. This is the one I want. If I indicate it, it's this one. It's also the one next to it, but that gets a little too close to this muscle because this muscle is going to be the levator labii superioris. So levator means elevate, bring up. Labii means lip. And superioris means it's the top of the lip. So that's this muscle here underneath. We'll go through those on a model so I can point them out to you, okay? So you're looking at, for the zygomaticus, you're looking at the corner of the mouth, going to the cheekbone, and then the levator labii superioris, you're looking more at the lip going upwards towards the eye. And then when we get to the bottom, we have a couple as well. We have the depressor anguli oris, and we have the depressor labii inferioris. So the depress means down, like we're depressed. Anguli means the angle of the mouth, and oris means mouth. And so that muscle is on the side of the mouth going downward. So it's kind of the equivalent of the zygomaticus muscle on the bottom. It's just see here, zygomaticus antagonist. They just don't mention the zygomaticus, the levator anguli superioris muscle or something. So, but on here they do that. So that's the depressor anguli oris. When you are doing the test and you get a little, I give you guys enough time for the test, but you get a little nervous, just go to the names. Just break down the names and slow everything down and take a deep breath, and that should hopefully help. Then we have another muscle. Let's see, maybe this is easier. See that next to the red one, that's this sliver here that goes downward, but it's on the lip of the lower lip. And that muscle is the depressor labii inferioris. So that comes out of here. So the anguli, depressor anguli oris is on the side. So you have that angle of the mouth. And the labii inferioris is on the lip, pulling it down. That's the pouting muscle. I don't like it kind of muscle. And then we have two more on the side, and one of them is the boxinator. And the boxinator is a deep muscle that goes back. That muscle is really, really powerful in babies that need to suck when they drink the milk. And so that's the vacuum cleaner muscle, I call that, because they just sucks everything in. If you ever held a baby and had your finger in their mouth, which I'm not so sure, but if it's your own kid, you get to do that if the hands are clean. That's like just a little suction place where, you can just put a bottle and it just sucks. And the boxinator is the muscle that really does that. It's also the muscle that causes dimples. And so that's a fairly deep muscle. And superficial to that, we have the risorius muscle. And you see the risorius is a sliver of muscle that lays on top. So if you have a small little sliver going from the corner of the mouth backwards to the jawbone, or actually the muscle here, that's the risorius. The deeper one, the wider one, is the boxinator. All right, and that brings me to the chewing muscles. And we have 4 chewing muscles, but we're really talking about the ones we can see from the outside in this class. And so they're listed right here, or they're showing right here. We have one that goes to the temporal bone, and they call that the temporalis muscle. And that's where that coronoid process comes in, because they attach to the coronoid process and closes the mouth this way. And then we got the second one, and that's the masseter muscle. And that starts at the zygomatic arch here, or the zygomatic bone, and it goes down to the mandible, and it pulls the mandible down up this way. So it closes the mouth in this direction, and the temporalis a little bit more in this direction. So you have a lot of force as you close the mouth. We then also have another one that's like the masseter, but it's on the inside. So the mandible is like a sandwich, 2 muscles, one on the inside, one on the outside, and that closes the mouth from that angle. And then we have one more, the lateral pterygoid, and that is a small little muscle attached here. And when that contracts, it pulls the jaw forward. So it actually helps with opening the mouth. But you don't need to worry about those. All right. Now, if we're done with that, then we go to the next part. part. This is like Speedy Gonzales here, huh? Axials. I know, right? Oof. I know. Yeah, slow me down if you need to. I'm watching the time. And I'm just going through the terms.
I think my laptop's about to die, so I'm gonna join back on my phone really fast.
Yeah. Okay, good.
I'll be right back.
All right, cool. I'm gonna continue. So then we go back to the bones, and now we go to the axial skeleton, and that is when you look at the skeleton, you have, wait, I described that here on the skull, I believe. You have an axial and an appendicular skeleton. So we have a skeleton that's sort of the axis of our body. That's the up and down. That's the spinal cord, the skull, the rib cage, the breastbone, the sternum. And then you have the appendicular skeleton, and those are basically the appendages, the legs and the arms. And so we first gonna cover the axial skeleton, and then we're gonna go into the appendicular skeleton. So let's.
Do we have to worry about the joints?
No.
Oh.
I know I should, as a chiropractor, I should make you study joints, but I have a lot to say about joints. But no, I'm not going to worry about joints in this class. But you can ask me questions on it, that's for sure, okay? It just gets so vast of material. So when I look at a vertebra, I got a typical vertebra. So we got different sections. We got a section in the neck, that's the cervical section. We got a section, no, that's not even the right picture. We got a section in the mid back, that's the thoracic section, low back section, and then we got the sacrum and the coccyx. So all these vertebrae are pretty much, except for the top two that are a little different, they're pretty much looking like all the same, except like the top ones are smaller than the bottom ones, and they have a few differentiating features. Like if you look at the mid back, the spinous process that goes really farther down. In the neck, it goes more back, and in the low back, it also goes more back, and is a big spinous process. Some of the arrangements of the facet joints are a little bit different. And so, but what we do for our understanding, we look at a generic vertebra that shows us pretty much all the pieces that we want to know about in most of those vertebral bones. So, of course, the one thing is the body. And if you have a big thing on a bone, it's often called the body. That's a pretty good word for that. And so that's actually anterior. So that's going through your body, and then you when you go through the gut, you feel the front of the body if you get to go through that. And then from the body going backwards, we have two pillars of bones coming out, and those are known as the pedicles. So we want to know that. And then we get to the side, and there we have a process that comes up to the side, and that's known as the transverse process. Those are muscle attachments. And then, well, some joints for ribs as well. And then we have the lamina, which is going basically from the transverse process backwards to the posterior end, which is the spinous process. And the spine, if you touch the back of your neck, you feel those bumps, and those bumps are spinous processes. All right. I lost all audio now, huh?
All right. So I went back onto my laptop because I found my charger.
Oh, that's good.
Yeah.
I know. All right. Then we go to the next bones. And so we have an atlas, we have an axis, and then we have a sacrum. In the homework, I make you guys differentiate between the little things that are different in the vertebra. But for the test, we're just going to label the bones. And so the atlas is this ring-shaped bone. That's the first bone on top, the C1 bone. And then this is where you actually can see it better. And so that bone does not have a body. the body is missing. And the body actually is, the body of C1 ends up becoming this dens or odontoid process that's sticking out from C2, which is called the axis. And so that's sort of the remnant of that body on C1. And what if you put those two vertebrae together, you can really see how you can do nice rotation on that joint. And so this is where a lot of the rotation that our head does comes from. About 50% actually comes from there. And so this complex is what helps us say, no, I don't want this, I think. The nodding up and down comes from a lot of it comes from the occipital joint, the occipital condyles that are on the skull connecting to C1. Good, so that's that. And then from there, we can basically jump right to the sacrum. And the sacrum is one of my favorite bones because it's called the sacred bone. And so I think I described that in the quiz. But watch out, I'm sure that bone's on the test. There, what I want you to know is the top portion is the wider portion, and that's the base. And as we go inferior downward, we get to a narrower end, and that's the apex. And those terms are there. And then if you look, this is a frontal view. So you're looking from the front to the sacrum, and you see these lines here, or ridges. These are where we used to have the intervertebral discs. And so they call them, they go across, so we call them the transverse lines, or also the transverse ridges. Hold on real quick. And then what we do then is we're gonna turn the sacrum around and look from the back. And in the back here, you see the remnants of the spinous processes. And the sacrum are few, I should have said that first, the sacrum are about 5 fused vertebrae together. So sometimes you actually get people, they have one extra disc in here, and they have one of these segments that's supposed to be sacrum, it becomes part of the lumbar spine. They call that lumbarization. And so those people have a little bit more back pain. So, well, it depends actually, because we don't necessarily know if they have that condition or not, unless we take an x-ray. But the remnants of the spinous process become what's called the median sacral crest, which is, if you actually touch behind your, in your butt, in the midline, you can feel the sacral crest. That's in the back. It's like the bumps in the neck for the spinous process. Good, so that's for that. And then with that, if there's no questions, we go right to the rib cage. And when we look at the ribs are kind of cool. Now, why are they cool? Well, they're protecting the lungs. That's kind of nice. They can also give us a lot of, if you have stabbing upper back pain or something, some ever had, that's usually a rib joint, because the ribs, they go around from the front to the back, and they attach to the, you can see it here, they attach to the vertebra on this transverse process and on the body as well. And this picture is actually a little wrong, because they usually attach in between vertebrae. So when we go back to the generic vertebra, we can see that. See that little flat piece here? That's, they call it a demi-facet. A facet is a flat surface that makes a joint. And this is sort of a half joint making thing. And then the other demi-facet is on the vertebra above or below. Anyway, that's detail as probably too TMI, probably. But I don't mean to confuse you. So if I do confuse you, just slow me down. But when we look at, so that's how they attach on the spine. And so if something is a little raunchy here, every joint that's sort of a freely movable joint has a skin around it to protect it, because you have a little fluid inside that joint, so the cartilage can be nourished, and the exchange can happen. The cartilage doesn't have blood supply, so it has to get fed from liquids like the joint fluid in there, synovial fluid. But if that skin can get caught in that joint, and that hurts like crazy. So that's a pain that's like a knife stabbing back pain feeling. It's very distinct. So if you ever have that, just shoot me a text and we'll figure out what to do about it. When I look at the ribs, I got 12 ribs altogether. I got 7 ribs that when you look at it and you trace them back, they connect directly to the breastbone, which is the sternum. And so they are called true ribs, and that's why they're called true ribs. If you look at the next one, number 8 goes into the cartilage of number 7. So the blue stuff that you can see here is cartilage, because you breathe, right? So the chest needs to move around. So you can't have just bone. That would be kind of hard, like bricks. You can't move those around. So you need a little cartilage to have some give. And so if you actually touch in your breastbone and you go right next to it, you can push in a little bit and it's a little give. It's not just sturdy. And so that's the cartilage that you feel. And so the false ribs are all the ribs that don't directly have a cartilage attaching to the sternum. And the lowest 2 ribs are actually floating ribs because they don't have any cartilage at all. They're just floating around there. And so those, you just need to be careful not when you massage somebody, if you massage somebody and you massage their back, you want to kind of go from the pelvis outward a little. Be careful if you poke one of those. But if you do, they're going to tell you because it's going to hurt. Just be gentle. I had a patient and she has heavy scoliosis, and scoliosis is a side curve bending. And one of her ribs, when she came in with a pain, and we figured it out at some point that her lowest rib was catching the pelvis, and that was a pain. And so if we straightened out the spine with some, work and made the pelvis level, she could be walking better for a while because that wouldn't be the case. So that was pretty interesting. That's applied anatomy there. And that's how I think about these things, structurally, what could be what. The knowledge I accumulate gives me ideas to what could be what. And so, I think you're starting in that process, and hopefully that course gives you more of that information so you can, either ask the doctor good questions or actually learn yourself a few things about what to do. Anywho, then what we need here is the sternum. The sternum is the breastplate and it has 3 parts to it. It has a top part that's known as the manubrium. So that's right on top here by the jugular notch. You can put your finger in there in between. If you poke too hard, you choke yourself. But right underneath there's this indentation. That's the jugular notch. And the bone, the top bone is known as the manubrium. The main bone is known as the body. Again, it's a good term to use for stuff like that. And then the lowest part is known as the cyphoid process. And that thing is quite delicate, because what happens is there is a muscle called the diaphragm. And the diaphragm is a muscle that's a dome-shaped muscle that goes inward and attaches to the vertebra, attaches to the ribs, and attaches to the cyphoid process. It's like a parachute that sticks up. And when you breathe, that is actually the muscle that contracts and it goes down. And by doing so, you increase the volume of the lung cavity, and that's inhalation, because the lungs are attached to the chest wall, or suction. They're suctioned to the chest wall. And so we'll talk about that when we get to the rib chapter. I mean, the respiratory, the breathing chapter. So that's pretty cool. However, if this breaks, this is very delicate. You can touch it on you. It hurts. If you poke too hard, it probably hurts because it's pretty pokey and it's often cartilage, but has some bone in it. And if that breaks off, because sometimes, well, how would it break off? Well, sometimes people choke. And when we choke, that means we have a food stuck in the windpipe and we can't talk, because the talking happens right here where the Adam's apple is. And the air can't go past it. And talking is basically when air going past chords like guitar strings, and they vibrate them, and that makes the sound. And so when somebody jokes and they have food going down the windpipe, they can't talk, so they make some signs and stuff, and then somebody knows the Heimlich maneuver. Have you heard of the Heimlich maneuver? Anybody?
Yes, I have.
Oh, good. So the Heimlich maneuver is when you take your hand, you go behind the patient, you take your fist and you basically push in and up really heavily, and that increases the pressure, and it hopefully pushes the food that is lodged in the windpipe back out. Now, when you do that, you have to be careful not to break the cyphoid process, because that can be dangerous. And so when you do the Heimlich maneuver, you take one fist, like if you're right-handed, you take the left fist or hand and hold it over the cyphoid process, and then you take the other fist and go below, kind of like above the belly button or right by the belly button, and then from there you do that maneuver. We'll talk about it as we get to the respiratory system. I think I have a couple of slides on that maneuver, but that's the relevance of the cyphoid process. It's the attachment of the diaphragm, and we want to be cautionary not to break that, because the thing is, if it breaks off, the diaphragm is so strong it yanks it back, and then it pierces the liver. It's like a little knife. I know, huh? Cool stuff. So that brings me then to the ribs themselves, and we have a couple of, well, we have the true, false, floating ribs, and then on a rib we have a couple of terms. We have a rib head, and that's the part that attaches with the vertebra. See here, you have two little things. One goes with the vertebra above, and one goes with the vertebra below. And then we have a narrower end, and that's known as the neck of the rib. And then we got a tubercle of the rib, and the tubercle articulates with the transverse process. Articulates means it makes a joint with the transverse process. So those are the three terms there on a rib itself that I need you to know. We don't worry about this here. That is where the cartilage starts, and that here's the rib angle. But we don't have that as a term. Bene, bene. How is that? Can you still handle it?
It's a lot, but it seems cohesive.
Good. So we have one more. I know this is part of the thing I ask a lot of attention, the attention span. But let's do the last chapter, which is the appendicular skeleton, and then I want to do a brief quiz. Oh, and I want to talk about the dissections briefly. And I think then we can call it a day. Let's see if that opens. Come on. So the appendicular skeleton is arms and legs. And so we start with the arms, and then we go down the legs. Yeah, see, we do a lot of terms on this list. Uh-oh, come on, baby. There we are. So when I look at the upper extremities, the first thing I want to check out is the shoulder. And the shoulder girdle is made up of the clavicle, which is the collarbone, and then the shoulder blade, which is the scapula, which is in the back here. And so we have another picture here that shows those two like that lined out. And then here's the motion. So the shoulder is really cool because it's really flexible as can be. I mean, look at all the motion. You can bring that whole arm up, and you still can carry something in your hand, and it's strong enough. And of course, we just go through life not even thinking about it. But it's remarkable how flexible the shoulder joints are. And of course, what that comes with it is some vulnerability. And so a lot of times shoulder joints can get injured or wear out. Like frozen shoulder syndrome, for example, is when some of the muscles become hardened. Because a lot of the shoulder, what holds the shoulder together is actually muscle. We only have a joint, the only joint that attaches the whole arm to the chest, to the axial skeleton, is right here, where the clavicle comes together with the manubrium. And that's not really a joint that holds things up. The clavicle is not really a strong bone. It's actually the most frequently broken bone in kids, because they can, well, everybody can fall with an arm stretched outward, but the kids get that bone broken quite frequently. And I've seen a lot of people who had that collarbone broken, and it just, grows back and or fuses together. and is usually not the biggest problem. All right, with that, let's just dive into the scapula. And the scapula, when I look from the back of the shoulder blade, the shoulder blade, I have this ridge, and this ridge is known as the spine of the scapula. So if you take one hand and you put it on top of your shoulder, the opposite shoulder, and you feel a ridge, a bump, that's that spine of the scapula. And you can take that spine of the scapula and you can go all the way to the tip of the shoulder. And if you do that delicately, you touch this acromion process, and that's the tip of the shoulder, the end of the spine of the scapula. And then it goes down a little bit, and the next bone you feel that's sticking out slightly on the side, that's then the upper arm bone, the humerus bone. That's the humerus. So that's the spine, that's the acromion. And then above the spine of the scapula, we have an indentation that if you probably touch your spine and go above it and press on it, it probably feels somewhat good because that muscle is working heavily all the time. But the area on the bone is known as the supraspinous fossa. So supra means above the spine of the scapula, and fossa is this indentation. And we got one below, and that's known as the infraspinous fossa. And then we actually have one underneath. If you turn the scapula inside out, the area that's towards the rib is also its own space, and that's the subscapular fossa. And we got multiple muscles. We got muscles attached here going towards the spinous process. We got muscles attached here that wrap around to the rib cage. And we got a whole fat muscle here that goes onto the arm and yanks the arm inward. And we'll talk about those next week when we get to the muscles. I am so excited about the muscles. That's always can't believe we only get 1 day. I should have made 2 days for that. Anyway, another term that I want you to know is the coracoid process. And you can see that best when you look from the front of the scapula because it comes out of the front of the scapula. It's this weird little handle thing, this bar that sticks out. And in class, I walk around with a skeleton next to me when I can, and to remember the coracoid process, I always visualize there's a raven sitting on the witch's shoulder and says, coracoid, coracoid. And so when I, do quizzes or so, people seem to remember it that way. But this is a muscle attachment. If you are on your own body, you can sort of feel it as you grab the spine of the scapula, go to the front here, or the side, that's the acromion, and then you fall down to the humerus bone. And then what you can do though is you can go to the front, and right next to the humerus, you have the humerus bone, and you have a little bump. And that little bump is the coracoid process. And if you push on it, it kind of hurts. So if you test yourself on that. There's 3 muscles attached there, and we're going to talk about them. All right. And the last one here on the terminology I need you to understand is the glenoid cavity. And the glenoid cavity is on the side here. It's where the humeral bone goes in, the humerus goes in. And so you can sort of see this picture here is from the side. It's a side view. And so you see it's fairly shallow, and the humerus goes in. If you look at the humerus has this head right here, and that head attaches into the glenoid cavity right in here. And it's shallow. And so what the body does, it makes a cartilage ring around it to hold it together. And they call that the labrum, L-A-B-R-U-M. And maybe some of you had heard of labrum tears. Talk about football. The receivers get the labrum tears a lot because they're reaching out with their arms to grab the football. And of course, there's other sports too, but I've seen it in football players a lot where the labrum gets worn out. And again, it's cartilage. And so you injure a cartilage and it has a little break in it. There's no blood vessels in the cartilage, so it's really difficult to heal. So if you see no blood vessels somewhere, you understand it's very difficult to heal. It's actually sometimes it's easier to heal a broken bone than heal a broken ligament or a torn ligament. Anywho, those are the terms I want you to know for the scapula. I don't need you to worry about medial lateral border. That's just becomes a little semantic and difficulty to visualize where we're at. But that brings me to the humerus. And the humerus is the upper arm bone. And we have a head of the humerus. Maybe it's easier to see here. The head of the humerus is the round structure. So you see something round and you don't know what it is, a head is a very good guess. And then we have a couple of necks. And guess what? Under a head is a neck. And so they use that and apply that to the bones too. So we have a narrowing, although this first neck here is called the anatomical neck. That's not really narrowing, but it's underneath the head. And then we jump over these bumps here. There's two bumps we're going to talk about. And then the bone really narrows. And they call that the surgical neck. And the reason why they differentiate that is because this is sort of the true neck, so to speak. But the surgical neck is the one that they have to do surgery on, because if somebody breaks the humerus on top, the proximal humerus, they likely break the surgical neck. The most vulnerable part of the humerus up there. And then we get to bumps, and we got a greater tubercle and a lesser tubercle. And the greater tubercle is the bigger part. Greater means bigger, and the lesser is the smaller one. And this is an anterior view. So you see the lesser tubercle is in the front, and the greater is a little bit more to the side. What happens is the muscles that attach to the tubercle, when you see the word tubercle or you see a bump like that, you're sort of assuming it's going to be a muscle attachment, because why the heck else would you have that? So the why question is actually a very important question for our class. It's not, you're not going to annoy me like a parent if you always ask why, because the body does not make for the most part, it does not make things that are not necessary. Actually, I think for all parts, it does not make things that are necessary. Some things might get a little bit less important with evolution, depending, like a small little toe might be not as important as the big toe, but there is always a reason why we have a part of the body. And so it is with the tubercles. And so you see a bump, it's a muscle attachment. And so what attaches to those bumps, to those tubercles, are muscles that, one muscle that sits up in here, and two muscles that sit in here go to the greater tubercle. And that's the one that's more on the outside laterally, though that makes sense. That's the backside of the shoulder blade. And then the lesser tubercle is where the muscle from the subscapular fossa comes out and attaches to that. And those four muscles are known as the rotator cuff muscles. And we'll talk about them next week, but they hold the arm, they hold the shoulder, the arm into the shoulder blade. I think I mentioned it here in the muscles. See, there is muscles that anchor the scapula to the trunk. We talk about those. Those are the ones that go more towards the trunk. And then there are the muscles that attach. They don't anchor. I call it, they attach the arm to the scapula. And those are those rotator cuffs that we were talking about. Those are those that go to the greater and the lesser tubercle. And then, of course, we got muscles that move the arm around, and we'll get to those later. All right, there is your tubercles. And then what else we got there? We got the deltoids, tuberosity. So see here, the term tubercle and then the term tuberosity. It's actually the same term. It's just they refer, generally speaking, a tuberosity is a bigger bump and a tubercle is a smaller bump. But as you can see, when you go down the arm, you go like, where's the bump here? There's hardly any bump. But they still call it a tuberosity. Sometimes in the text, you also have these referred to as tuberosities and not tubercles. And so just know that's the same thing. One thing that annoyed me greatly learning all this material when I learned is like, when the names are slightly different, I'm thinking, oh, that's a different structure. And I question myself. And so I want to try to give you as many AKAs as I can. And I think I put a whole bunch of them in the booklets too. All right, from there, and the deltoid tuberosity is a muscle attachment. It's this muscle attached to the deltoid muscle. And we'll get to that next week. And then we have two bones down in, two parts of the bones down in here. And this best viewed from the back side. We have, when you go down the arm, you feel like on the inside, you feel this bump that you probably hit sometimes. And it hurts because that's like skin right over the bone. And that's the medial epicondyle of the humerus. So a condyle is the word that we use in the mandible. Remember that mandibular condyle makes a joint with the temporal bone. And a condyle is a round structure that makes a joint. And an epicondyle, epi means above, and so that's above the area that makes a joint. Now, this is confusing because they don't call this here condyle. They call it trochleum. They call it the capitulum. I'm not going to make you study those terms. But those are, technically speaking, if we go with a system, they are basically condyles. In the leg, it's much easier to understand that. But they still kept the terminology for what's above the condyle. So the bumps above the joint are epicondyles. We got one on the inside and we got one on the outside. And they become very, very important muscle attachments. Like the medial epicondyle here. Oh, let me take this off and see if I can visualize it. The medial epicondyle is right here. You see that bump, or you can sort of make it out, I hope. And the lateral epicondyle is on the outside. The medial epicondyle are attached, all the muscles that go to the hand in the front of the arm, the forearm. And the lateral epicondyle are where the muscles attach that go to the backside of the forearm. So that's where that becomes important. And those muscles are quite intricate, but I try to explain them to you in a way that you hopefully can take home and understand. Good. So that's the humerus, right? No, the olecranon fossa. Ah, right here. What a nice term. When you look at the elbow proper, when you put your elbow on the table, you touch the elbow proper, and that's actually a forearm bone. That's the ulna that we talk about next. But that ulna, let me explain this to you as a picture. There it is. That ulna has this hook on it. And that hook, like that joint here, fits into this joint here, and that hook sticks into here. That's why you can only extend an elbow straight. You can't go too far back unless you break it, but we don't need to do that. And so the stoppage point of how, when you straighten out your elbow, where that hook here, that part is stopped by the other bone, that's the olecranon fossa. That's the part that stops the arm from being extended further. So that I wanted to know that. Olecranon fossa, I wanted to know. And then we get to the ulna. And on the ulna, I wanted to know the bone. And you see that hook, then you know it's the ulna. The other thing you know, if it's the ulna, because in the forearm, you have two bones. You have an ulna and a radius. And the ulna always goes towards the pinky finger, and the radius almost always goes to the thumb side of the hand. So that becomes important when we talk about muscles, because a lot of these muscles are described as in ulnaris or radialis, like what bone do they run parallel to or superficial to the bone. So that's good to know that. So the ulna goes to the pinky, the radius goes to the thumb. And then we have the olecranon process, which is that hook. When I label that hook, that's the olecranon process. So on the humerus, you got the olecranon fossa, and on the ulna, you got the olecranon process. I know, a little bit much, isn't it? But we got to keep going. And then we got a radius, and the radius is the one that goes to the thumb. And what I want you to know there is we have, on top, we have a round structure. And you can probably feel that. That is the bump is the back. And then you go to the outside and you kind of can feel a little round structure here, or a little, little not easily made out kind of stuff. But the lateral epicondyle, and then you go dip in, and then what you feel next is the radial head. And the radial head. And because the reason why we have that head like that is because when we bring the palm from supine to prone, when we go palm down, this bone actually reaches over and it crosses the ulna. And so that round motion happens up here. That's why this thing is round. And then underneath the head, what we have underneath the head is a neck. So then there's a neck of a radius. And then after that, we have a bump. And that's known as the radial tuberosity. See, that bump is not that big, but they call it the tuberosity. They don't call it the tubercle. So again, those terms are a little bit loosey the way they use them. So just go, if you see something says radial tubercle, you know it's the same thing. This is actually where the biceps, part of the biceps muscle attaches to. And the biceps is that big muscle on top that some of the guys need to show off. That's the biceps muscle, but we'll get to that later. Then the other thing that I didn't talk about, the radius or the ulna, are as you get to the wrist, they come to a tip, because when we look at the wrist joint, you see how there's a rounding to the wrist joint a little bit, and then you have the carpal bones, the wrist bones after that. And that's where the wrist bends, is where the carpal bones are. And the end points of these two bones that make that rounding structure are known as styloid processes. So you have an ulnar styloid process, and you have a radial styloid process. And again, styloid is like in the skull, it refers to pen. So it's like a little thing you can, sticking out. So that's the visualization. And then we got the carpals, and I'm not going to make you study all the individual carpals, but I want you to be aware we have 2 rows of carpals, and they basically help us with up and down and a little bit of sideways motions. They are pretty important, clinically speaking, but it's just those terms are so confusing. I don't know how they came up with all of those terms. But that's something you get to look up. That's why they're in the book. And then after the carpals, we have the metacarpals. And the metacarpals are the web of the hand. They're not fingers. They're where the web of the hand is. And then after the metacarpals, we have the phalanges. And we have 3 phalanges on every finger. That's why we can bend them on 2 different places. And we got 2 phalanges on the thumb. That's why the thumb, you can only bend it in that one joint up there. And so that's the upper extremities. And from there, if nobody has anything to say, I'm going to go straight to the pelvis and the lower extremity. The pelvis is the big structure here, as far as I'm concerned. We love the pelvis. Clinically, the pelvis is really, really important with my work, because if you have, let me look at it. If you have the hip is not quite balanced, let's say this side is a little higher. Very often the right side is a little higher. You have some of these muscles that are imbalanced from side to side. But what happens is the spine comes up a little crooked, and that puts some pressure on these lumbar vertebrae. So that's where the pelvis, which is the translation from the forces below that translate into the spine, becomes very important clinically speaking. Okay, we have on the pelvis, the pelvis is basically made up of 3 bones, and they are color coded here. You got the top bone, that's the ilium, and then you got a bone in the back where the sit bone is at, and that's the ischium. And then you got a bone that brings the hip together in the front. And if you go underneath the stomach, you feel a bone in there, and that's the pubic bone. So that's the whole thing is a pelvis. And this is called, when you look at the joints, this is called a synostosis. And so these bones are fused together before we're born. And so they become one. So I want you to know the iliac crest, which is where the baby sits up. That's on the side of the hip. And then you follow the iliac crest to the back, you get to a big bump that you can feel, and that's the posterior superior iliac spine. And so if you go backwards on that crest, you will reach a bump that's sort of on the top portion of your butt, and that's the PSIS. If you go all the way to the front, you follow the iliac crest to the front, you have another little bump, and that's pretty edgy. You can sort of feel that joint as you touch that, and it can be a little tender, and that's the anterior superior iliac spine. Anterior superior iliac spine. Okay, and then we go back to the back because I forgot a term. So we have that big bump, then we have a little smaller bump. We don't worry about starting that for the test. And then we have a big indentation here, and that's known as the greater sciatic notch. And I don't know if any of you heard of the term sciatica. Have you? Sciatica?
No. No.
No. Okay. Sciatica is what people refer to. Often they come in, if they want to say, I have really bad back pain, they come and say, I have sciatica. And so that is an indication. But what it really is, it's an indication of an inflamed or irritated sciatic nerve. And the sciatic nerve is the main big nerve that goes all the way from the butt down to the foot in the back of the leg. And that nerve comes out of here, that sciatic notch. It's about the thick of your thumb. It's not as, no, it's about as wide as your thumb. It's a big nerve. And so if that gets compressed there, we're going to have symptoms down the back of the leg and the back of the thigh. So anyway, that's why they term that sciatic notch. And then we have an area here that's on the side that on each side, that is where the hip, the femur fits into it. So if you look at the femur, or you see it right here, where the femur goes in, that place in here on the hip is the acetabulum. On the femur, it's going to become the head of the femur, which is nice. We have a head, we have a neck, and then we have a few bumps. That's like almost similar to the humerus, if you think about it. Or it's very similar to the humerus, actually. Just bigger. So that's the acetabulum. And then as we turn the hip around, let's go to that. We have the iliac fossa, and that's the front part. This part is actually a very important muscle attachment area. Muscles go down into the leg, onto the inside of the thigh, and those become the muscles that raise up your thigh from the front. So if you sit, that muscle is working, or at least it's contracted. If you raise your thigh, that muscle is working. 2 more points here. We got one is the sit bone. That's known as the ischial tuberosity. That's the sit bone. And then we got, so that's actually the bone you're supposed to sit on when you don't slouch. But of course, I'm not a good example, so I better be a little quiet about that. But that's when you sit up straight, you're sitting on your sit bone. You're not sitting on your sacrum. Like, you know, I think of slouch sitting, you're sitting on the sacrum here. And then the other term on there is the pubic symphysis. And let's see, do we have it attached here? Pubic arch. Oh, here. Pubic symphysis. That's the joint where the tooth bones come together in the front. So I make you study that term. And you see, that's a joint. There's a cartilage. That's actually like an intervertebral disc. Like in the backbone, there's the discs. It's the same material than that. It just doesn't break as much, thank God. And then from there, we go right to the femur. And so we have the head, we have the neck, and then we got a couple of bumps. And we have a big one, and we have a smaller one. This one is actually on the medial side. So that's really hard to access if you have to palpate it. But the big bump on the outside, you could feel that. You just feel for a big bump on the outside of your butt. That's what the greater trochanter is. So it's known as the lesser trochanter and then the greater trochanter here. And then what else we got here? We got then, and those of course become muscle attachments. So essentially, pretty much the muscles that attach here, look at that, for most of them go into the greater trochanter. Even the medius, the gluteus goes in there. So we'll talk about those next week. And then as we go downward in the back of the thigh, in the back of the femur, we have a line, and this is known as the linea aspera. And this is a place where we have a lot of muscle attachments. We have the adductors attached in there. So the adductors are muscles that adduct the thigh. They bring the thigh inward. So it's kind of nice. They call them adductors. That way it kind of goes together with the motion. So that helps. And then also the quads, the front of the thigh muscles that straighten out your knee, they wrap around and they go attached to that. And that gets us an understanding of how powerful those muscles actually are. So the linea aspera is pretty important in terms of muscle attachments. And as we get distally, we get to the condyles. See here, they have condyles. And so these make joints. So we have a medial one on the side of the head. That's on the medial side. And then we got a lateral condyle. And the condyles make a joint with the tibia, which is this lower leg bone. The big leg bone is the tibia. And so the tibia has a plateau, and the condyles sort of sit on that plateau, and that creates the knee joint. What I like here is the rounding. If you actually it's not, they call it a hinge joint, but it's not really a hinge. When it rounds, it doesn't, when the knee joint rounds, it doesn't do this. It's more like this is the tibia, this is the femur, more like it moves on that plateau and it gets guided through that motion. So that's just a little FYI on the side. But that's where we have these menisci. I don't know if you ever heard of people have a meniscus tear or meniscus injury. It happens with sport, but then it also happens as people get older and these become a little more brittle. The menisci or the disc structure, that type of cartilage is known as fibrocartilage, and we studied that in the first chapter, and that's kind of like the old Tupperware kind of plasticky thing. That's sort of the construction or the feel of it. So it's pretty hard plastic. And then the last term that I have on the femur is the patellar surface. And so the front of the knee has a patella in it right here. It's a sesamoid bone that's inside a tendon. And it helps smooth out the motion as we straighten out the knee. So when we contract these muscles, when we contract them more, they correspond to the amount of contraction to how much the knee moves. In terms of the force transfer, it's not like if we wouldn't have a patella, the muscle would go there and then go straight down, and there's too much of an angle. And so when there's too much of an angle, then you would have to exude a lot of pressure here before you get any movement in the leg. But then once you start moving the leg, it will kick real fast. So it'd be very hard to control that motion. And so the patella helps with that. Good. And that's the next bone is the patella. So that's the patella bone. Even though a sesamoid bone is very different than a regular bone. A regular bone has a lot of blood supply going through. A sesamoid bone is more like an accumulation of calcium that sits inside a tendon. But we still call it a bone. So don't, that's just so you understand the difference. And then we get to the tibia. And the tibia is the main weight-bearing bone that brings the weight down from the knee to the ankle. The outside bone on the lateral side here, there's on the outside, that's the fibula, and that's a stabilizer. It helps stabilize the leg, the lower leg, for the most part. Of course, we have a lot of muscle attachments there too. They do interplay heavily, though. They have this thick interosseous membrane in between that if like basketball players or so, they jump all the time, that gets stretched out because each time you put force down from the foot upward, those two bones separate a little bit. And so the interosseous membrane is very important, holding them together, but it can also be worn out. And so then people they have compartment syndromes or so where the muscle really gets tight on the lower leg. So that's something that sometimes needs to be worked on. But anyway, back to the tibia. On top of the tibia, we have condyles, like on the femur. We have a medial condyle on the medial side and a lateral condyle on the lateral side. That's where the femoral condyles attach to the tibial condyles, and that makes the knee joint. Oh, and then I need you to know the bump in the front of the knee, and you could probably touch that on yourself. That's the tibial tuberosity, and that's where all those muscles here, all the quads ultimately attached to is here. They come together into the patella, and then from there they reach down into the tibial tuberosity. And so it's interesting. They call a tendon is a connection between a muscle and a bone. So they call this the quadricep tendon because these are all the quadricep muscles. But then they can call this from the patella to the bone. They technically call this the patellar ligament because a ligament is a connection from bone to bone. However, clinically speaking, we often just call it, the quadricep tendon all the way down because when you work it and you treat it, it works sort of as a unit. All right, and then the last term here on the tibia is the medial malleolus. And you probably, if you bicycle, you potentially hit that before and it hurts because it's, again, a place where the bone is right underneath the skin. And so if you can touch the inside of the ankle, and that's the medial malleolus, so you can feel that. And then the fibula, the term on the fibula that we have is the lateral malleolus. So that's on the outside, a bump on the outside. You can also feel that or see that. They call that lateral malleolus. And see, that makes a nice little round structure that then the ankle can sort of embrace, or the lower leg can embrace the ankle. You can see it here, can embrace the ankle. See here how the force comes down through the tibia, and the fibula is on the outside. And so then the last two bones I want you to know are the calcaneus and the talus. And this yellow here, oh look, the T fell off. Should say talus. This yellow bone is the talus, and so that's the main bone that the tibia corresponds with and brings the force downward. And then from there, see here is the darker blue, and from the talus, the force gets distributed forward to the forefoot and backwards to the heel. And the heel bone is the calcaneus. That's a pretty big bone that I want you to know. I'm not going to worry about all the other ones here because these are the tarsal bones, the navicular, the cuneiform, the cuboid. Again, that's just so much more terminology. But then from there, we get like in the hand into here they're metatarsals, not metacarpals, because the wrist bones are the carpal bones and the ankle bones are the tarsal bones. But it's the same thing. And then we get into the toes. And again, we have 3 joints. Even the little biggie toe on the outside, the pinky down there has 3 bones in it. And the big foot, the big toe bone, the big toe has only 2 bones in it. And so, but I'm not going to make you study that down here because we did the same in the hand. It's just the same thing. And so that way, that's why it's not on the list. All right. How is that? Any questions?
No, not any for me.
Lots of chat.
It's a lot of information to take
I
in.
know,
But
right?
not very many questions.
I know. Let me make sure to go through the chat real quick. So yeah, wrong spelling on the test. Please do the best you can. Makes my life easier, but you will not get you'll not get taking points off. What do you say there, Junka? Who's on the video lecture? Oh, that was my kid, huh? That was my other kid.
Yeah.
That was my older one. I have 2 of them. Yeah, I know. I wanted to make these videos as interactive as possible, and so for 1 or 2 chapters, I had Darby work with me, but then it's just too much work. And then do we have not? So no, you don't have to worry about the joints in terms of the test. So have that be, understand as much as you can, but that's passive stuff. And then is the linea aspera only in the back of the femur? Yes, the linea aspera goes down the back of the femur. Let me point that out one more time. So only on the back of the femur. So it's only, this is posterior. That's where we have the linea aspera. This is anterior. We do not have that. Good. All right. So having said that, what I want to do to finish isn't the linea aspera. No, that's the linea alba. The one in the stomach, Janko, you think? That's the linea alba. It's called the linea alba. Good thinking. Yeah, you guys doing great work, great integration work, because it certainly is a lot of stuff. And so what I want you to do now is, I'm very mean. I want you to take out a sheet of paper, and for about 5-10 minutes, I'm going to do a little quizzing on you. So if you can't do it because you're at work, Janko, don't worry about it. We'll do what we can, okay? But if you, Hannah and Natalie can, that would be great. And if you can, then you're good. So let's take out a sheet of paper, and I want you to tell me if you can see can you see my skull?
Yeah, we can see the Word document of pictures.
Perfect. So Just write down, we do about 10 terms and then we go through them and just do the best you can, okay? It's not anything that counts. It's something that should help you for getting towards the test. Well, the first term we already did. We don't even worry about that. I want you to tell me, what's this bump on the back of the head called? The bump on the back of the head. And I'm going quite fast. If you don't know it, that's totally fine. But the bump on the back of the head. And
do you
then
want to say it or just write it
no,
down?
just write it down. We'll do this.
Okay.
We'll do this solving afterwards. And then the second term I want you to tell me is it's not as good of a picture, but there's a bump in the back of the ear that you can touch, that when you press hard, it hurts a little bit. What's that landmark? I should say, what's that landmark called? Number 2, that's number 2. And then number 3, I want you to tell me the muscle that goes from the corner of the mouth to the cheekbone. Oh, yeah, we have that. Corner of the mouth to the cheekbone. Number 3. Number 4, I would like you to tell me the muscle that's on the side of the mandible. That's a chewing muscle that goes from the mandible up to that cheekbone, the zygomatic bone. Ooh, I just gave number 3 away. Ooh. That's number 4. Number 5, I want you to tell me the bone. What's this top vertebra called? What do we call that bone? The top vertebra, right underneath the skull. Holding up the skull like the Greek mythology thing that it's named after. Good, that's number 5. And then number 6, I want you to tell me the landmark, not the bone, the landmark, that's the bump in the back of the vertebra. It's posterior. It's the stuff you can touch when you poke yourself in the neck. So that's number 6. What's that landmark called? And then I want to go right to, what's this bone called? This whole bone right here. What's this bone called? That's number 7. The bone, that's in the butt, the lowest part of the spine. What's that bone called? And then number 8, on the shoulder blade in the back, we have this ridge. It's the one that you can touch with yourself when you bring the hand to the opposite shoulder. What's that ridge called? And number 9, I know I'm brutally fast. Number 9 is in the pelvis. So you have this iliac crest, that's the ridge, and then you go back, and you find this bump. What's that big bump in the back of the pelvis called? And you can abbreviate all those words with the first letter of the words. And last but not least, number 10, I want you to tell me what's the heel bone called. Number 10 is the bone in the back of the foot, the heel bone. Good.
What did you ask for number 9?
Number 9, I asked the bump in the back of the pelvis. So you go on the iliac crest, you reach backwards, and then it gets wider and bigger and becomes this bump. It's a long word, or it's multiple words. Good. So what I want you now to do since we got this ginormous class, usually I have like 15, 16 students or so, I want you to shout out the answer if you know it. Everybody. What's number one? Nobody?
I
Yeah.
put the occipital
Good. Very good. It's the external occipital protuberance. Protuberance. I know, not protuberance. Protuberance. I was doing that wrong for about 15 years.
Wait, how did you pronounce it?
I used to pronounce it protuberance, but it's protuberance.
Occipital
I know. External occipital protuberance.
Oh.
Go ahead.
External occipital protuberance.
There you go. That brings it into the head.
Yeah.
And if you want, you can call it EOP.
EOP. Okay.
So once we just, I think I actually accept that as an answer if that's on the test. So you know, if there is an abbreviation, EOP is cool to use, because it's just a long friggin' word. And then number 2 is that bump behind the earlobe. What was that called? Anybody or everybody?
I put it as. Go ahead.
Oh, the mastoid process.
Yes, that's the mastoid process. Very, very good. And then we go to some muscle here, and I did the muscle that goes from the corner of the mouth to the cheekbone. That's number 3. Anybody got that?
Is it the
zygomaticus?
Zygomaticus. Good. Which one you had, Natalie?
I was wrong. I was gonna say Risorius.
Oh, no, you know, that's not that far off. The risorius is right here. So you see the risorius is this sliver here.
Mm-hmm.
The zygomaticus is this sliver. So if you see it go to the cheekbone, you know it's the zygomaticus, because that's the zygomatic bone. The risorius is often confused. The sliver is the risorius. The deeper one underneath is the boxinator. So that's where those come in. So very good. Number 4 is this one here. What was that? You all got that?
The masseter.
Yes, the masseter. Very good. And then from there we go to number 5, which is the bone here.
I did not get 5 or 6.
Okay, Hannah, you got it? That's the atlas. Very good. And then number 6 is the bump in the back of the spine. I almost gave it away.
One, I put transverse process.
Almost. The transverse process is here on the side, and the one sticking back is the spinous process. Spinous process. It's kind of like this, where you can feel the spine when you touch on your own self. So that's probably why they call it spinous process. I'm not totally sure about that though. And then number 7 is a whole bone, my favorite bone.
Is it the coccyx?
Almost. The coccyx is here. I would probably take coccyx if you put that on the test, actually, because the coccyx.
Tell if you wanted sacrum or coccyx.
Oh man, you are definitely differentiating. That's perfect. Yeah. So the coccyx is the lowest portion, and then the sacrum is the bigger one. And see on the list, I don't think I list the coccyx. So make sure on the test, Hannah. I mean, I'll go through it, and if you give it the right stuff, I'll totally take it. But you're only responsible for the terms on the list. If it makes that, that should make it a little bit easier when it gets to.
Yeah.
But again, I'm going through it. If you use other terms, it's totally cool. I mean, if they're the right terms. And then number 8 is this ridge in the back of the shoulder blade.
I didn't get anything for 8, so Hannah, if you got it.
No, I didn't get 8 or 9.
Okay, 8 is the spine of the scapula. So that's that ridge in the back of the scapula. And both of you guys, I can guarantee you, you're doing both much better than most of the class. So don't feel bad if you miss a couple on this. This is pretty tough being put on the spot just with the three of you, but you know, you're the only ones who can talk. So the spine of the scapula is that term. And then number 9. Did you get number 9, Hannah?
I
No.
thought it was the sacroiliac joint, but I wasn't sure.
That's good. It's not on the list, but that's sharp because the sacroiliac joint is right here between the sacrum and the ilium. And what I was pointing to was the posterior superior iliac spine.
Oh, okay.
And that's another one where you can call it PSIS. You don't have to spell the whole thing out. So make a note of that. There's also the anterior superior iliac spine. You can call it ASIS, as in as is, which is my favorite section at IKEA. But I'm not sure if you guys have IKEA up there. We have it in Emeryville.
Yeah.
And when I grew up, go ahead.
I said, yeah, we have IKEAs.
Yeah, but when I grew up in Switzerland, the first IKEA outside of Sweden was in my neighborhood.
Oh, really?
So it was there in 1977, and so I knew IKEA growing up. So there always is an as-is section, which is where you want to go look, because sometimes you have great finds and then they don't cost anything.
Yeah.
But that's how I remember that stuff. As goofy as can be, right? But the last question I have, number 10, was the heel bone. Did any of you get that?
I don't know how to pronounce it. It's like
calcaneus. Calcaneus, yes. Calcaneus. I think they can also pronounce it calcaneus. So it's kind of like with this language, you know, you can, with these terms, you can almost pronounce it in a way you want to, because they're used around the world. And believe me, French-speaking people pronounce it a little bit different than, you know, Americans. So that's perfect. So we call it the calcaneus or calcaneus. Good. How was that? Did you guys learn something from doing that?
Yes, definitely.
Good. So with that, I think we can close it out. Look at that, right? The dot for 2 hours. That was good timing. And you have great attention span, that's for sure. But I think we can leave it. If there's no other questions, we can call it out and close it out, and let me know what's going on. Just shoot me a text if you have something, unless there's something right now. You got something?
No, I don't have any questions.
Now you need to go out for a walk or something. Oh yeah. Oh, thank you, Janko. I'm working on the text, but I put an announcement in the canvas that we will have Merced. This is my first semester in Merced, but the other professors, what they did is they did a take-home dissection kit. And so they prepare different organs that you can pick up, and then we can do some dissections at home. We have a sheep heart, a sheep brain, a cow eye, and a kidney. And we're going to do those at home. And so what you need to do is you need to, next week, and it's in the announcement, next week, she said, what did she say? Her name is Alexandra von Stade, and she has these dissection kits ready in Science Room 116. Do any of you guys know the Merced campus?
I do.
Yeah.
My mom works there.
So you can find Science Room 116?
Yeah.
Hopefully. And she said she can be there from 10 a.m. to 1 p.m. And I hope that, and she could be there the whole week.
Oh, the whole week?
For the whole week, Monday through Friday. So she's available those. She has a door with, you know, a thing where you can see it. Okay, yeah, that would be great, Jan, because I have no idea about that campus either. I haven't been there myself on campus yet. And then the only other thing that she said the other professors make the students do is buy the dissection kit. And I found some dissection kits at Amazon. And how the heck am I going to be able to show you that? I just put in on Amazon, what did I put in? Dissection toolkit. And I can ship you some. They're like under $20. There's one for $18. There's one for $11, and two for $11 that I see there. Do you want me to? You know what I'm going to do is I'm going to put that in a text. How about that, Janka? Would that work?
Yeah.
I'll put that in the text. And if I'm spacey about the text, please, you guys have to be my canary in the coal mine and text me tomorrow. Hey, what's up? Text that thing out, please.
Okay. What room did you say it was in again?
It's gonna be Science SCI 116.
Okay.
116. And I put that also in the text. I put it in an announcement on Canvas already.
Is it next week or like?
Yes, she's there from the 19th to the 23rd to pick up from 10 to 1 o'clock. And I hope that works for most people. I have to figure out what to do. I have one student from LA and one is in San Francisco, so I'm not sure what to do with them. But if you guys can pick that up, I think then after that, because next week, at the end of next week, we finish up this part, the muscles, and then we get into the heart. Cool?
Sounds good.
Wonderful. All right. Well, I really appreciate you guys' participation. It's kind of nice to have a small class like that. It makes it nice and personable, right? Just do some chat around it. But for everybody else who missed it, I will post this as a recording. Oh, good. I did record it. And make sure, please make sure to keep the quizzes handy. All right? Because I'm trying to guide you towards test stuff. All right? So keep those answers in your notepad. All right?
Okay.
Good. I know, right? We'll try to make it so it's feasible, not too complex. Okay, with that, we can close it out. Any last questions?
No.
Good.
I just wanted to say for Janka, she said she doesn't know where the science building is. It's the building right behind the Leisure building. It's like a circular, big old building. It's kind of like the main building on campus. The science building's right behind that, and it says science on it.
Yeah, it'll be, as long as you look, it'll be kind of hard to miss.
Okay, super. So there's a map or something that you can see.
Yeah, I think that's what she
Yeah,
said.
I think
Look at too.
they have like a one in the middle of campus too, like a big one.
Oh, super. Yeah. That's good. Yeah, I know. I have to get down there too at some point, but it's like 3 hours for me, so I have to figure out when that is. It's a day event.
Yeah.
All right. Well, have a wonderful evening, y'all.
You too. Have a
And
great
thank
rest of
you.
your week as well.
Yes, you guys do. And keep in touch, okay?
Okay.
Reach out if anything comes up. Bye.
Bye.